Okay, let me start. Okay. Okay, shall we start, Prof?
Yeah, sure.
Sure, no problem. Okay. So, for today, this is probably a bit too advanced for the medical officers, but just bear with us. Okay, so this is basically, to me, this is an advanced topic. So basically, we are assessing the pharyngeal and the UES disorders on the high resolution manometry based on the Leuven consensus. Uh, I'll have to admit that this is not an easy topic for me to tackle because I've never done this before, and the concept pretty much is an alien one to me. So if there's any factual error, I would like to apologize and I would like to be corrected here lah. So that's
Yeah,
a
sure.
big major disclaimer from me. Uh,
No problem,
uh,
but that's how we learn.
yeah. Okay. So, and I just found out that Leuven is actually a city in Belgium. So that will be in my bucket list for
Yep.
travel later on.
So yeah, I've
Yeah.
been to Leuven. It's a
Uh,
very nice
mm.
medieval city. Mm.
Oh, okay.
Yeah. So you,
Mm,
you have
mm,
a chance. I think it's good that if you can
uh,
visit there. But of course,
uh,
most people don't when they want to go to Belgium, they don't start with Leuven. They tend to start with the other cities in Belgium like Ghent,
yeah.
uh,
Mm,
Bruges,
mhm,
uh, some of the other cities lah. But
mm,
definitely Leuven is yeah, another
mm.
like you say your bucket list.
Yeah, yeah, yeah. I didn't know about this. So yeah, bucket list. So this is based on the Leuven consensus papers. So basically, what they are trying to do is to try to define the pharyngeal and upper esophageal sphincter disorders on the high resolution manometry, which is not an easy task. So they are trying to establish a standardized classification system to diagnose pharyngeal and upper esophageal sphincter motor disorders. So, to me, as a beginner, I think about this as the Chicago classification equivalent for the pharynx plus UES. Uh, so, this comprises of international expert panel, and the document summarizes the final recommendation. So, basically, the what they have defined is defined swallow challenge protocol. And then the criteria for diagnosing UES dysfunction and the criteria for diagnosing pharyngeal dysfunction. So, but the caveats, they've put in the caveat. So the caveat is basically this pharyngeal high resolution manometry should be used as a complementary assessment of the upper airway. So the advantage is it may detect abnormalities such as altered bolus transit or airway protection not identified by manometric assessment. And even though the pharyngeal manometry is reported to be normal, you cannot label this patient to have normal swallow. So and this is to the consensus said this is basically a diagnostic tool, but they in any way they cannot really recommend any clinical intervention based on these findings. So there's no guidance given in regards to the clinical intervention. So, what are the indications for the pharyngeal manometry? So, basically, the intervention would be complementary or adjunctive diagnostic test for swallowing assessment following VFSS and FEES. And some information can be gleaned from the manometry that can be missed from the VSS and FEES. I look at the pharyngeal manometry as more of a way to guide the rehabilitation process or to or to see whether the pharyngeal dysfunction is due to structural issues such as obstruction, US obstruction, or it can be due to neurological issues, for example, Parkinson's. Uh, so
Yep,
it'll
that's
be
correct. I mean,
so it'll be
yeah,
interesting to get an input from the speech and language pathologists in regards to their rehabilitation process and whether this pharyngeal manometry will help them. So I was thinking maybe I can talk about this again during our shared uh, ACME with the speech and language
section with
pathologist later.
exactly.
Yeah.
I think this is good if we
Mm,
can
mm,
also share with them
mm,
that
mm,
at least I'm sure by now you will realize
mm,
it's such an important to have a collaborative
mm.
effort when assessing patient with dysphagia.
Yeah,
So
correct. Yeah.
you're seeing for
Mm,
yourself
mm, mm,
FEES, there's
mm-hmm,
some subjectivity assessment there,
mm-hmm.
correct?
Yeah.
Yeah.
Yeah, yeah,
And I
it's
think the
mm, mm.
I think the manometry will provide some objective assessment in addition to face, then will give us a more complete picture.
Agreed, Prof. Agreed. So, so this is a decision tree defining the utility and timing and the additional clinical information that can be gained using the pharyngeal high resolution manometry. So, if you have an oropharyngeal dysphagia complaint, so the first thing that the decision tree suggests is to get a FIS or a video fluoroscopy. Uh, and if it is clear, if we have a clear treatment plan based on fees, they actually recommend proceeding with the planned treatment and rehabilitation. But most of the time, and this is what I've encountered in the dysphagia clinic as well, is when there is when the fees were done, there will be some subjectivity and there will be some arguments in regards to the correct or the proper treatment plan in regards to rehabilitation. So this is where I think the pharyngeal high resolution manometry will actually help in terms of treatment. Uh, and this is what has been suggested from this division tree based on these papers. So this is another way. This is another table showing suggested indications and contraindication for pharyngeal high resolution manometry. So they strongly suggest doing PHRM when we are suspecting US dysfunction based on history or other instrumental tests. When they are when quantification of propulsive and restrictive forces is needed to guide treatment decision or to determine baseline swallowing functions. And this is something new to me, which is to measure the changes following intervention. For example, myotomy, botulinum toxin injection or dilatation, or as an objective biofeedback during rehabilitative treatment. They do also suggest doing PHRM in patient where the VFSS is difficult or cannot be performed, which to us will be basically the availability of VFSS, which is not, this thing is something which is not widely done, at least in the Ministry of Health settings. And we need and they also suggest doing this to rule out any swallowing dysfunction in context of possible functional dysphagia and to quantify the progression of degenerative neuromuscular disorders, monitor objective changes of swallowing over time, or to identify subtle changes in swallowing when previous instrumental assessment are deemed normal or do not provide explanation for symptoms. Uh, so there are some contraindication which I think is quite self-explanatory. Non-significant nasal obstruction, history of trauma to the nasal cavity, high risk of bleeding, or inability to comprehend or follow obstruction or agitation, or inability to tolerate manometric catheter. So I think this is something that's I think quite common sense. Something that the same contraindication that applies when we are doing esophageal manometry as well. So I do apologize, but I try to simplify these slides in a way that I can understand it as a beginner. So correct me if I'm wrong. So the big picture is basically when you're swallowing, you have this oral phase where it's mainly mastication. You basically you put your food in the stomach in your mouth, you chew, and then you prepare the bolus for the oral transport phase, and then you push it into your pharyngeal muscles. Your UES relaxes and opens, and it flows through the esophagus. And the Leuven paper is basically asking which step is failing. So pharyngeal muscles, I think about pharyngeal muscles as the pushers. So the main muscles, there are three layers. There are superior, middle, and inferior constrictors, and the function is to contract from the top to down sequentially, and it push bolus towards the esophagus. And the inferior constrictors has two parts, which is thyropharyngeus, then cricopharyngeus. The cricopharyngeal muscles is a horizontal fibers, and it forms an upper esophageal sphincters. And then the disorder, and then basically there was a condition called a cricopharyngeal bar, where the cricopharyngeal muscle becomes thick, and it can actually obstruct, and this is basically and this can also cause dysphagia. So I think of US as the gate. So I do put a lot of analogies here, Prof, because this is because as a beginner, I want to try to simplify things as much as possible. But if this is wrong, just correct me as I go along. So I think of US as the gate. So the main component is the cricopharyngeal muscle. At rest, it is closed. During swallowing, it relaxed and got pulled open, and it needs neural relaxation and higher laryngeal elevation to pull the larynx up and forwards and physically open the UES. And then there was bolus pressure from the pharyngeal contraction, pushing the food bolus past the upper esophageal sphincters. It's like squeezing the toothpaste from top to bottom. This is how I think about the process. Uh, so you can actually measure this metrics of upper esophageal sphincter relaxation and opening. So there is normal versus incomplete relaxation. So you can actually measure the integrated relaxation pressures. And I just found out that you can the IRP when it is measured for the US, you measure it over 0.8 seconds instead of 4 seconds. Am I right, Prof? It's a very short period.
Yeah,
Uh,
that's
uh,
correct. It's
uh,
different from
uh,
the
uh,
IRP in the lower esophageal sphincter.
mhm. Uh, it's just that the way I'm not sure whether we can actually do it in our ZVU diverse attack system. I'm not too familiar. I'm still trying to familiarize myself with it. And then there's also some other parameters that we can actually measure, which is normal versus impaired US opening or distensibility. So there is something called a US maximum admittance, which measures the maximum bolus cross-sectional area. Okay, so basically it measures the opening of the opening of the passage that the when the upper esophageal sphincter opens, and the hypopharyngeal intrabolus pressures, which measures the bolus pressure above the UES. This is akin to the bolus pressurization that we measured on the esophageal manometry. Uh, so based on this bolus pressurization pattern, uh, they can actually they can determine whether there is any possible UES restrictions. So the two pattern of pressurization, which is pharyngeal pen pressurization and distal compartmentalized pressurization, are indicative of sustained UES restriction. So this is akin to pushing a bolus against a closed gate. So obviously there will be an increased pressure prior to that. So and this indirectly suggests that there is some upper esophageal sphincter restriction. So there is also a transient pressurization. We are not sure what's the significance of this, whether it's functional or coordination issues. But the thing is, based on the studies, this thing can be seen in healthy controls. So whether this is significant or not remains to be seen. But the paper do agree that the two pattern of pharyngeal pen pressurization and distal compartmentalized pressurization are indicative of sustained upper esophageal sphincter restrictions. Uh, this is a very complicated pictures, but basically, I'm what I kind of want to focus is the type 1 and type 2. Type 1 is the pan-esophageal, type 2 is the compartmentalized pressurization. So this is the sphincters. So as you can see, as you swallow, there is this dotted rectangular box shows an increased pan-esophageal pressurization from the initiation of swallowing up to the upper esophageal sphincters, up to the nadir of the upper esophageal sphincters. So this actually shows this actually is kind of an indicative of some obstruction at the upper esophageal sphincters. With type 2, the pressurization was high and was compartmentalized and it's mainly at the distal region. So this actually shows, this is also kind of indicative of upper esophageal sphincter obstruction. So indirectly, if you have pressurization, there is some disorders at the upper esophageal sphincters. This is how I understand this, Prof.
Yeah, correct.
Yeah.
So it's
Mm, mm,
something
mm,
similar to what we observe with
mm, mm.
the lower esophageal sphincter also. The
Yeah.
concept is similar.
Mhm.
So if you have any kind of pressurization, we should always think about whether the sphincter or, like you said, the gate
Mm-hmm.
is obstructed or not.
Okay.
Yeah.
So, sorry. So that's that for the upper esophageal sphincters. So there are also metrics of pharyngeal contractile dysfunction. So we have talked about the gait. So we are now talking about the pushes, the muscles. Yeah. So as when we're talking about esophagus, we are talking about DCIs. So for upper esophageal sphincters and for pharyngeal muscles, there's also a contractile integral that can be used to measure the pharyngeal muscles. So it's analogous to the DCI of the esophagus. But uh, to complicate things further, they have divided the pharyngeal muscles to a three functional region for so three to four functional regions. So basically, there's nasopharynx, which is above the soft palate, velopharynx, which is junction at the soft palate and posterior pharyngeal walls. There's mesopharynx or oropharynx, which is the region from the soft palate to epiglottis, and then the hypopharynx, which is from epiglottis to the UES. So this is from top to bottom. So nasopharynx is the seal, velopharynx is also the seal and initiate the pressurization. Mesopharynx is where the main propulsive contraction happens, and the hypopharynx is the final push towards the US. So they is for such a short for such a short anatomical region, they complicate it and they they divide it into four different regions for a good reason. So respectively, each segment can be measured and is expressed by its own contractile integral. So there's VCI, there's MCI, and there's HCI. So each parameters describe the vigor of the pharyngeal muscles. So low CI, low contractile integral basically means low vigor. High CI means high vigor. Uh, so yeah. So as you can see, this is basically how it is seen in the manometry. So you have nasopharynx, velopharynx, mesopharynx, and hypopharynx. And this is and this is how the impedance reading are shown. Yeah. Uh, so basically, from my readings, what they have they try to divide this because basically, if there's a specific weakness at a certain region, it is indicative of a certain pathologist. For example, if it is mainly at the mesopharynx, especially at mesopharynx or velopharynx, it is actually indicative of a neurological issues. For example, Parkinson disease. But if it is mainly at the hypopharynx, then especially if it is hypercontractile, uh, it may not really be due to the neurological issues. Instead, you may actually have some degree of upper esophageal sphincter obstruction, which triggers the US to hypercontract to compensate. This is what I understand from the papers lah. Uh, but I'm going to talk about this again later. So swallow protocol. This is the suggested swallow protocols, but based on this, I would also like to get some opinion from you, Prof, because I have from my experience, whenever we actually do an esophageal manometry for somebody with uh, pharyngeal issues or oropharyngeal dysphagias, trying to get the patient to swallow liquid is actually very, very difficult. So this protocol actually says try to give 5 milliliter thin liquid at least 3 times. But from my experience, this in real life, this is also quite problematic. Most of them will just vomit out the liquid straight away, and especially if the fees has said that the swallow is quite unsafe. So I'm not sure whether this can be done or not. But the swallow protocol has suggested that if this is not going to be tolerated. They suggest increasing the viscosity to 5 mils. Sorry, they suggest increasing the viscosity of the liquid swallow. So if you can tolerate 5 mils of viscous liquid and then try to increase the amount. So it's basically a stepwise fluid challenge. Baseline is 5 milliliter of thin liquid. If you can get this down, then push it to 10 milliliter thin liquid. And if you can get this down as well, push it to 20 mil, which I think is quite a lot. But if you can't get 5 milliliter of thin liquid, then increase the viscosity. And we have seen how this can be done during our dysphagia clinic, where they actually have a fluid thickness and they basically have a certain grading, IDDSI grading from 1 to 4. This paper has not really said what kind of viscosity should be used for the pharyngeal manometry, just that a broad statement that if you can't tolerate thin liquid, use a liquid with high viscosity. Do I get that right, Prof? Do we
Yeah.
do that here?
Now, in
Uh,
in our center,
uh,
what we used to do is to use thin liquid 5 mils for
uh,
3 times and
mhm.
15 mils.
15 minutes.
Because yeah, that was
Mhm,
during the time of On,
mhm,
where or was it Navin?
mhm,
Uh, we found that 10 mils and also
mhm,
5 mil did not give a lot of difference. That's the reason why
mhm,
our swallowing protocol for the pharyngeal UES
mhm.
would be 5 mils and also 15 mils of thin liquid. And you are
Okay.
right and this can be whether or not you use a thin or viscous fluid, it can
Mhm,
be guided from FEES.
mhm,
If you are if just say the patient during EFIS,
mhm,
they can not tolerate the thin liquid, then straight away I think we should go to the viscous protocol.
mhm.
And again, on what kind of viscosity will depends on what is the viscosity used during FISO.
Okay. Yeah.
Yeah,
Agreed.
which is
Agreed.
why
Mhm, mhm,
Hizami is. I
mhm.
think we should have our own lab swallow protocol.
Yeah. Mhm,
Uh, this
mhm,
is just a
mhm,
guidance from Leuven, but
mhm.
it's better that we have
Okay.
our own swallow protocol.
So you will start with thin liquid and then you will increase the amount lah,
Yeah,
because
we can discuss this. Is I
uh,
mean, I think
uh,
as a
uh,
separate
uh,
session,
mhm,
we need to develop our own protocol,
mhm.
and also we need to talk to our nurses
Sure.
on this. I
Okay.
don't think this session is we
Enough.
can discuss on this. It's going to be
Okay.
quite a heavy,
Yeah, yeah,
especially
yeah.
when yeah, it's not meant for our like you say lah,
Okay.
our medical officer here.
Yeah, yeah.
Mm.
Sure. So yeah, so this is the suggested flowchart for diagnosing US dysfunction. It's kind of to me, I found this to be quite logical and it kind of makes sense. So you start with the swallows. Sorry. You start with the swallows, and if the majority of the swallows shows two abnormal features. For example, there's intrabolus pressurization or the IRP is abnormal. And then it shows evidence of US dysfunction. But if there is no, if the majority of the swallows shows no raised IBPs or the US IRP is normal, then there is insufficient evidence of US dysfunction. Uh, but again, this is they kind of highlight that this uh, pharyngeal manometry is basically a complementary test. So you still need confirmatory investigation by FEES or fluoroscopy. Yeah. This is they give an example of an unequivocal UES dysfunction. So this is basically a case of a cricopharyngeal bar. So uh, cricopharyngeal bar means there is an upper esophageal sphincter obstruction because of the thickening of the cricopharyngeus muscle. So you can see from the dry swallow looks okay, but in the thin swallows, you can start seeing this intrabolus pressurization, and as you increase the amount of fluid and the viscosity, the intrabolus pressurization is quite dramatic. So, and if we quantify it, then you can see that the IBP goes up as the amount of fluid and the viscosity goes up, as well as the IRP and the US maximum admittance. So yeah, the same thing goes to the pharyngeal metric as well. So uh, at the mesopharynx, it started going up because it's trying to compensate and push the bolus against a closed gate. Uh, so this is another example of a 48 years old lady post radiotherapy with cervical web. So a dry swallow looks okay, but as you increase the amount of fluid and the viscosity, you can actually start seeing this intrabolus pressurization, and and objectively you can also see the readings go up when the amount of fluid and the viscosity goes up. Another example, a 64-year-old inclusion body myositis with a cricopharyngeal bar. So this is a dry swallow. So as you increase the amount, you can actually start seeing you can actually start seeing the integrated relaxation pressure, the UES pressures increase. So this is green, and it started becoming red because the IRP goes up. Uh, so that's that for UES. So for assessing pharyngeal dysfunction, also not too complicated. So the flow chart is quite straightforward. From what I gather from this, if you have if if majority of the bolus swallows are absent or low across all pharyngeal segments, if it is all pharyngeal segment, then it's global pharyngeal hypocontractility. If it is some pharyngeal segments, it is fragmented pharyngeal hypocontractility. So I think this is almost analogous to absent contractility plus ineffective esophageal motility on our esophageal manometry, where there is a total versus some ineffective swallows,
Mhm.
peristalsis on the esophageal manometry. Uh, but if the majority of bolus swallows demonstrate high contractile pressures in some or all segments, then it is pharyngeal hypercontractility. Again, they have mentioned this again and again and again, and I've also said it again. Most of the time, it's a compensatory phenomenon, often observed in conjunction with an upper esophageal sphincter dysfunction. So, so if there is hypercontractility, think about US dysfunction first. If this has been ruled out, then only can we think about possible other causes such as neurological issues. Yeah. If none of this is present, then this is not a pharyngeal contractile dysfunction. And they have given a lot of examples for this. And I think this is quite an easy diagram to understand. So this is normal. So this is global pharyngeal hypocontractility. So you got somebody with medullary stroke or inclusion body myositis. So across the pharyngeal muscles, velomesopharynx, mesopharynx, or hypopharynx, there is absent pharyngeal contractility. So this is global pharyngeal hypocontractility. So if it is fragmented, for example, for this in this gentleman with unilateral vocal cord paralysis, or post radiotherapy and surgeries, it's quite fragmented. So velopharynx and mesopharynx are okay, but hypopharynx is low, or these patients where the velopharynx are fine, but the meso and hypopharynx are low. Yeah, so this is fragmented pharyngeal hypocontractility. In pharyngeal hypocontractility, you can see that, for the lack of better terms, everything is red. from the velar pharynx all the way to the upper esophageal sphincters. For example, in this patient with global sensation or vocal fold paralysis or post-bariatric surgeries or total laryngectomy. And I think this is quite an interesting uh, 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 quite an interesting thing to look for, because if we are doing fees, the only thing we can see is the thing that we see are very subjective, whether the bolus whether the bolus sits in the peripheral fossa, whether it goes into the trachea, whether it's safe or not, and it's very subjective. But this is something which is very objective. You can actually see the pharyngeal muscle contraction. You can actually see where the problem is. You can see whether it's hypocontractility or hypercontractility, and you can tailor your treatment based on this. Because, for example, if you have somebody with hypocontractility, the rehab will totally be different for somebody with pharyngeal hypercontractility. Uh, and so, in a nutshell, so this is how I think about it. When we are interpreting pharyngeal high resolution manometry, you have to think whether the propulsion is adequate, whether there is any resistance, or whether the UES is opening properly or not. So you can do this by measuring the contractile integral of the pharyngeal muscles, whether there is measuring the intrabolus pressurization, and measuring the IRP and the duration of the IRP. And I think this covers most of the basis of interpretation for pharyngeal high resolution manometry. So this is meant to be an overview, Prof, not a complete detailed study of the pharyngeal high resolution manometry, which I think is beyond this talk lah.
Yeah, sure.
Uh,
It
mhm,
is
mhm,
good enough.
mhm,
The other thing I would probably want to add is that
mhm.
pharyngeal and UES, these are all skeletal muscles,
Okay.
whereas
Mhm,
the
mhm.
muscle in the esophagus and the lower sphincter, these are all smooth muscle, except for diaphragm, which is a skeletal muscle.
Okay.
The lower esophageal EGJ, or the lower esophageal sphincter, and diaphragm both made up of the EGJ.
Mhm,
So it's quite different. Therefore, if the UES and pharyngeal muscle are skeletal in nature, means these are all under voluntary control, whereas the lower esophageal sphincter and esophagus are involuntary, is
mhm,
beyond control. So to some extent, the pharyngeal and the UES, there are some component of voluntary control there. And because of that, it's we are able to do rehabilitation.
mhm. Understand.
Okay?
Mhm,
Yeah. So that is one. We need to understand that it's skeletal versus
mhm,
smooth muscle in the esophagus. So that is one difference. And you are right, for a small structure, but there are so many muscles there,
mhm,
showing that swallowing itself is not a simple thing. It's a very complex process. Yeah. So that is probably the second thing that we need to recognize. The other thing really is the assessment. So the main tool that we have for assessing swallowing would be, like you say, the FIS, the VFSS, and then also the pharyngeal and UES manometry. I think they all play um, different complementary roles. And that's the reason why we have to work with the speech therapists and others in the MDT fashion.
mhm,
Now, treatment of dysphagia can be rather not so straightforward and require all this behavioral and rehabilitative process, which I think your talk um, is really crucial to allow our officers to understand that don't just brush away dysphagia. Even in patients with stroke or in any other conditions. So if someone who have a dysphagia you found in the ward, especially oropharyngeal dysphagia,
mhm,
it's good to call our speech therapist,
mhm,
or if there is a dysphagia team, it should refer them for further assessment of the pharynx and the UES. We do, and in our center, we do have such a team available, um, and therefore make use of this uh, multidisciplinary team in order to provide a much more better treatment for patients we have oropharyngeal issues.
Okay.
Okay.
Yeah. Yeah.
Now, I don't
So,
know, do you have any other questions, or are there
uh,
questions from anyone else?
mm, no. So far from your experience, do they tolerate manometry well for in somebody with oropharyngeal dysphagia? Because I I've recalled an experience. When I was in my previous centers, there was a young lady with 50 years old with they're investigating for unexplained tremors. At the same time, he has been having dysphagias on right hip for the longest of time. They couldn't find the cause. Had a lot of scopes. And referred to me. So as a trainee who knows not know who knows who doesn't know any better, requested for manometry. But during that session, uh, basically what happened is the patient uh, cannot tolerate any thin liquid, any liquid solids at all. So basically, she will swallow and she will retch and she will vomit the fluid out. So at that point, I kind of abandoned the procedures and asked for fees. Apparently, the fees wasn't done for this patient, but because everything is so slow, I kind of want to get the manometry done first. So in this situation, that's why I was asking a lot about the liquid swallow protocol. So whether this 5 mils liquid is adequate or whether you can actually do it with just dry swallow. uh,
Yeah, dry wouldn't
uh,
be
uh, uh,
very useful.
uh,
Yeah, so we have also looked at dry swallow
uh,
before, but
uh,
it wasn't very useful at all.
mhm,
And
mm,
between 5 and 10,
mm,
well, both are quite similar when it
mhm,
comes to the value.
mhm,
So the current movement suggested 10, which I'm also fine because our own data suggests 10 is also
mm,
okay. It's
mhm.
just that during our studies, we did not go beyond 15. And 10 and 15 looks
Mhm.
like too near to each other. That's why
Mm,
we chose 5 and
mm.
15 as
Okay.
our swallowing protocol.
Mm,
We do I wouldn't say that they are not able to tolerate. We do have
mm.
patients where we do manometry that they can tolerate.
Okay.
Yeah. If they cannot tolerate, there could be other reasons as well.
Mm, mhm.
Uh, so one thing is our center has the benefit of most of these patients, they have gone through FIS first.
Yeah.
Yeah.
Mhm,
So then at least we know what is the potential expiration risk
mhm.
in this patient before doing manometry.
Okay.
Yeah, most of the time we don't, typically I don't proceed with manometry straight away
Okay.
until the speech
Mm,
team
mhm.
or the dysphagia team has done assessment or even
Okay.
have already done the FIS, especially for those high risk patients.
Mhm.
Yeah. But in the lower risk one, where you see on our clinic, a then we can I think it's case on case basis lah.
Okay.
Some patient we can certainly order a manometry straight away, especially those with a lower risk patient.
Uh, have you ever intervened any patients with pharyngeal hypercontractility? There have been a mention about doing Botox injection for somebody with,
Yeah.
hypercontractility. Yeah.
So there was just to
Uh,
share one
uh,
case. There was a patient referred by a neurosurgeon,
mm,
and that patient has oropharyngeal dysphagia,
mhm.
but also a 7 nerve palsy.
Okay.
And the thing they were seen by ENT and speech at
Mm,
Kota Baru,
mhm,
but I don't think they proceeded with. We are not sure about exactly the FIS finding because the FIS finding suggests that there
mm,
could be some liquid collection.
Okay.
And then we also did our own manometry. What we found was the patient has a poor contractility over the velomesopharynx.
Oh, ho, ho, ho.
So this is
Mm,
not a global hypocontractility, but a
mm,
fragmented hypocontractility based on Leuven, and it's
mm,
affecting the upper part of the muscle, the velomesopharynx.
mm,
Typically, we tend to pull velomesopharynx together. Lah.
mhm. Okay.
So in
Mm,
that patient, eventually, because he was also seen in our gut brain clinic,
mhm,
so one of the neurologists made an observation that, oh, actually her tongue is there's a fasciculation in the tongue.
mhm.
Yeah, and that's how he made a diagnosis of a motor neuron disease.
Oh, okay.
Uh,
Oh, wow. Okay.
and
Oh,
it fits
yeah.
with the
Mm,
hypocontractility in the velomesopharynx quite well.
mm, mm.
Hmm. So
Oh,
manometry
okay.
does help us to show
Mhm,
some a neuromuscular abnormality, and it
mhm,
helps us to alert further assessment by maybe a neurologist
mhm,
or something like that.
mhm,
Um, and therefore allow us to make a much better, a much clearer diagnosis.
mhm, mhm, mhm,
Okay, which is here. This is the whole idea here is we are trying to look at a dysfunction. Is there a dysfunction or not?
mhm, mhm, mhm,
And then we try to find out, is there a cause for that dysfunction? Just like exactly what we have done here.
mhm,
The example that I mentioned. So this patient has a some abnormal liquid pooling, right,
mhm, mhm,
from face, and then we did a manometry showing that she did have a velomesopharynx hypocontractility.
mhm.
And then subsequently, we referred to a neurologist, and then we got a diagnosis of motor neuron disease.
Yeah, yeah, that's very interesting. But one heck of a way to arrive to a diagnosis of motor neuron disease, Prof. Mm,
Yeah, but
mhm,
that is
mm, mm,
typically what happened because not everyone is a
mm.
neurologist,
Yeah, okay.
correct?
Mhm,
Yeah, it may
mhm,
be obvious to the neurologist, but not obvious to the non-neurologist.
mhm. Yeah, yeah.
And sometimes the
Mm,
patient they don't present to the neurology directly, but they go to other specialty, for
mm,
example, right?
mm. Yeah. Okay, so thanks for sharing that, Prof. That's very interesting. Yeah,
Yeah.
it just kind of highlight the power of pharyngeal manometry. Yeah, thanks a lot. Thanks a lot. Got no other question other than that. Whether the medical officers has any other questions? Or a bit too advanced for all of you lah.
I think this is an important thought. Again, I'd like to emphasize that when
Mm,
you see a patient of this dysphagia in the
mhm,
ward,
mhm,
don't just brush it away.
mhm,
We have a team here who can do a proper assessment. We have tools that can make a proper assessment of the dysphagia. And we have a team where we can do rehabilitative and other intervention to help with that patient with dysphagia. There are many other examples. I mean, what I mentioned is just one of the cases that we have seen. Um, in fact, if you know Navin recently told me also
mhm,
about his family, his relative, which
mhm,
was because he has done this before. If
mhm,
not, no one would have ever thought of referring his relative
mhm.
to a speech therapist, and later found out what is the problem with why the patient has a dysphagia. And
Okay.
he was very grateful in that he actually managed to go through this learning and therefore help his own relative.
That's yeah,
Mm.
it's it
Yeah,
it
and I can tell you a lot that
uh,
I can tell you there's a lot of other stories like achalasia, for example. A lot of people
mm,
don't even
mm,
know much about achalasia out there.
yeah.
So there are, for example, we have a patient who is a doctor.
Mm,
He's our own colleague. Going
Mhm.
around, everyone do a scope for him, but no one diagnosed him with the achalasia. Eventually, he got to know that he can do manometry here, was referred to our center, and he was diagnosed with achalasia, got a myotomy done, and he's very happy now. So each time he see me, he'll
Mm.
say very thankful to me because
Mm.
we are the first person who actually made a proper diagnosis, and he got better because of this. He been suffering from the achalasia for so many years, but everyone just do an endoscopy.
Mm. Yeah,
Mm.
yeah. We
So
need
this is
more.
just another,
We need
yeah.
we need more people doing motility, Prof. We don't have enough people doing this in the whole Malaysia.
Mm.
Mm.
Yeah.
Mm.
Okay, I
Yeah,
think
okay.
that'll be fine.
Okay.
That'll be all. Thank you
Mm.
very much, Isami.
Thanks a lot, Prof. Thanks a lot. Okay.
Yeah, make sure that you get recorded and save it.
Yeah, yeah. So this is recorded. I'll put all the